So fittingly, we'll be talking about pediatric eye conditions today. And what are the take-home messages here? I read some research the other day. I was reviewing a paper that said medical students have an attention span of about 15 to 20 minutes, not long, and it drops off, in the middle of the talk, and then it picks up again at the end. So I'll give you the take-home messages now. Kids' eyes are not the same as they're not like small adult eyes. There's a couple of things that are importantly different. And if you were going to pick one, it would be that there's a window for visual development that goes up until the age of about 7 or 8, after which time a kid's visual potential, their long-term vision, starts to become hardwired. So it's very important for kids to undergo visual screening, school screening, for vision and eye problems to be picked up and referred early so that you can get in during that critical window and give them the best long-term vision. That's probably the most important thing to take away. So what are these unique eye problems? Let's get into it. Their eye problems differ with ours. They can often accompany other problems, developmental delay, prematurity syndromes, systemic illness. So if you've got a sick kid, think about vision amongst the other things, even if they're too young to tell you. Time critical window we'll talk about. And yeah, it's a bit like veterinary medicine. You know, history can be absent and examination can be quite difficult. They're pretty squirmy. So we'll talk about some tips there. This is today's lecture. So we'll start with visual development and then how to assess a child's eyes. There's 4 core conditions that we need you guys to know about. And as a GP or, any non-ophthalmologist, there are obviously many other pediatric eye conditions, a retinopathy of prematurity, congenital glaucoma and other conditions. They're less common, so we'll focus on the more common and important stuff. Where does it fit in your syllabus or your curriculum? Well, these are urgent things. So pediatric squint, if a kid shows up with a squint or a strabismus, a deviated eye, people call it lazy eye, of acute onset, that's an urgent referral because that can represent something sinister. Leukocoria means an absent red reflex, and so often it's unilateral. So let's say you do a 6-week healthy baby check, they've got one red reflex that's present, another one that's absent, that's an urgent referral. Can represent a tumor. Is there anything else I'm covering today? No, really, it's those issues down there. So our learning objectives are basic understanding of visual development in kids, which we'll get into, and then the conditions themselves, a relevant history and examination of a child, and then diagnosis and management of the conditions that we'll go through. Feel free to interrupt, guys, with questions during. You don't have to wait till the end. So let's talk a bit about visual development in children. So what do we need for normal vision? Normal vision requires both eyes seeing the same object at the same time in focus, okay? Which means that there's a process called motor fusion, which keeps both eyes looking at the same target so that the eyes are aligned, right? They're aligned. They're looking in the same direction at the same time. If one eye is looking straight ahead and the other eye is looking left or right, you've lost motor fusion for some reason. And to get the sharpest view of something, which is like a 3-dimensional view, the eyes are separated on our head in space. So one eye gets one view, another eye gets another view, and then we fuse that image to create what's called a stereoscopic image, which means you can see in 3 dimensions. And the first 2 months of development are the most critical, but visual processing carries on for at least 7 years and probably longer. So we used to say if you haven't intervened by the age of 7 or 8, it's game over. Now we know that this window's, most of it still happens in that time period, but the window is a bit longer. And yeah, as I say, this allows human vision, which is high definition, color, it's binocular, and it's stereoscopic. And not all animals have this. So some of these features are unique to human animals. So when does this break down? Well, both eyes need to be in focus. So if one eye is not in focus, then you've lost one of those images. So if one eye has a high spectacle prescription and the other one doesn't, which kids can do, kids and adults can have, then you've got one blurry image, one sharp image. You're not going to have normal visual development. Or if there's a cataract in the way, you're not going to have a good image from one eye. Or if there's not a problem with cataract or refractive error, but there's a problem with the muscles the muscles that move the eye, the extraocular muscles. So for whatever reason, the eye's turned in or out, two eyes aren't looking at the same object. So this is when you lose normal visual development. And those things often go together. So if the eye's not seeing well, it will then often turn in or turn out. The brain sort of starts to ignore it. Amblyopia is what happens when the brain starts to ignore the image coming from usually one eye, so the worst image. So the connection between eye and brain starts to deteriorate. That's a first. Never seen that coming into a lecture late. Welcome. So the cortical areas that subserve vision are at the back of the brain, the visual cortex, within the occipital cortex, and the cortical development in those areas slows down or stops. Right, and the clock starts ticking as soon as baby's out. So if they're not seeing well out of one eye, that cortical development is delayed. And the plasticity, as I said, traditionally 0 to 8 years, but might be substantially longer than this. We now think into the teens to some extent, and beyond this, vision is hardwired. So how do you know if this is happening? How do you assess a kid with potential eye problem? Well, mum's always a good place to start, particularly if they've had other children, and they'll give you an idea of whether kids are doing what we call fixing and following, which means if you provide them with a target, let's say a torch or another target, and they can't be 2 days old for this, they need to be older than that. If you provide them with a target, then a kid of some weeks of age, and certainly of some months of age, will at least for a while be able to fix and follow a target. If it's an older child, then you're talking about detailed vision, which is picking up little things, and there's an element of fine motor that goes with that. But vision's certainly part of it. For older kids, are they bumping into stuff? Do they miss stuff? Do they consistently fall over or have accidents? It gives you a sense of visual field. So obviously this depends on age and stage. Do they wear specs? Is there a family history of needing glasses? When were the glasses last checked? Do you have any documentation of the prescription? Family history is super important. So mum and dad wear glasses. Do mum and dad have strabismus? Okay. Any family history of intraocular tumors? And particularly with strabismus, when we think the eye might now be turned and it wasn't before, do you have any photographs? The other thing that's useful for is leukocoria, where there's an absent red reflex. So in a photo, you'll see one red reflex is present and the other one looks dodgy, not symmetric. Okay. Examination-wise, well, just, like in all of medicine, start by observation. So an altered head posture, I saw a kid with this a few weeks ago. He's got his head perpetually turned to one side, but he's looking at you with his eyes turned. So that can mean a couple of different things. Is one eye visibly deviated? That's strabismus, or, lazy eye. Or do they have nystagmus? So nystagmus there's many different types of nystagmus, but in very general terms, it can mean abnormal visual development. So look for obvious stuff when they come in the room. Just watch the kid play, give them a toy. If you have toys, are super useful. If you end up being a doctor that sees children, have some in your room. So here's an altered head posture. He's turning his head to his right while he's looking at you. Okay. So in this case, he's turning away from a left fourth nerve palsy. He has got a left fourth nerve palsy, which I won't go into. We've got lectures online about cranial nerve palsies, but he's turning his head away for that reason, so that he ends up aligning his eyes. And by turning his head, he gets an aligned view, good view with both eyes. Fixing and following, I talked about. And if a kid has one eye that sees poorly, they will object to you covering the good eye, right? So even a baby will do this. So when you've got your target, cover one eye, then cover the other eye, and see if there's a difference in the baby's response. Cover the good eye, they're suddenly not seeing very well. They won't like that. So they'll squirm or turn their head or object in some other way. Can they follow a target? Red reflex, all infants within 6 to 8 weeks should get this done. I'll be doing it on our baby in the next few days. If I can find an ophthalmoscope somewhere in the hospital. And then at 4 months, then a school entry, and then as required thereafter. So it should be done multiple times in early years. And how do we do this? Dark room, ophthalmoscope, roughly at about arm's length. And make sure you're illuminating both eyes at the same time so that you can get a sense of symmetry. If you do one and then the other, you might miss something. And you don't need them dilated. If the room's dark enough, you'll get a red reflex. So I've done this on family members, infants. And we're comparing what? We're comparing the size, shape, the brightness, and the color. Okay, so they're the aspects that they're about the same size, same color, same brightness, and same shape. And if you have a look at the one on the bottom, you might appreciate his left red reflex is a bit duller than his right red reflex. That's the child in the bottom image. And depending on ethnicity, can be more yellowish or more red. So the key thing you're interested in here is symmetry. Yes, we've got a question. Yeah, it does. So you want them to be more or less facing you. So if you have a target or a toy which you or a parent can sort of hold around here to give them something to fix out so it's close to your line of examination. Yeah. And most kids will become interested in a torch anyway. You tell them there's a little star in there, sing Twinkle Twinkle. And for most kids, that'll hold their attention for long enough. Yeah. Yes, another question. Yes. That should be done. School entry should be done by the school as part of a school health check. 4 months, I can't remember, to be honest, off the top of my head. I don't know if it's done as a matter of routine. I'd have to check, but it's from memory, it's not solely on the GP. Not solely on the GP, but as you know, there's a schedule for vaccinations and there's a schedule for child health checks as well. Child health nurse definitely does the 6 to 8 week one. They may do the 4-month one as well. I'd have to check. Yeah. Any other questions about any of that? Yes. No, if you were to have a super bright light and hold it there for a long time, then potentially, yes, you can get what's called phototoxicity, but nothing that's commercially available on an ophthalmoscope or a little pen torch is going to do that. Good question, though. Back to your question about opportunistic screening. I think regardless of 8 weeks, 4 months, etc., do opportunistic. Just ask the question, observe them in the room. How do you think his vision's going? His or her vision. Yeah. And if you've got an ophthalmoscope, whip it out quickly. Another question. If you're far enough away from the kid, the field of illumination that the ophthalmoscope provides will cover both eyes. Yep. So it just needs to be sort of directly in the direction of their face, and you'll get both eyes. Yep. And you're looking through the little window, right? Yep. Yes. Mm. Yeah. Yeah. Yeah, look, I guess if you could put everything we've talked about so far into lay language, so you could say, look, it's really important that we check babies' eyes. It's actually a normal thing that's done for all babies in Australia. And the reason we do it is to catch vision problems before they become hardwired, because we've only got a certain window of time to do that. So this is actually in WA Health Paediatric state guidelines, is that these checks should be performed at a certain point in time. Mum, what are you worried about? What are you actually worried about? And she might say, oh, you might damage their eyes. No, we won't damage their eyes. They may not love it, right? They may not love it, but it should only be for seconds. And there is no way a pen torch or an ophthalmoscope for seconds is going to damage anything. Yeah. Okay. Looking at the sun damages your eyes. So there was a solar eclipse earlier this year. That is relevant to kids because we've had a number of kids, unfortunately, in WA who have gone on to develop solar retinopathy. So there was a lot of public health messaging that we did in the lead up to the solar eclipse, but that's one thing to definitely not look at, child or adult, but kids are more curious and they won't know about solar retinopathy, so you need to be especially mindful. Here's another part of the assessment, which is a corneal light reflex. This is a way of checking whether both eyes are aligned, right? And what you're looking for is the reflection of the torch or ophthalmoscope. This should really be torch, probably more useful. And what you're looking for is that it's in a similar position within the pupil. It's going to be very difficult to do this on any kid that's under 4 or 5. You can try, but in an older child, it's more useful. So if you have a look at the top one, that's normal alignment. The second one down, it's their left eye, your right, as you're looking. Left exotropia, which means the eye is turned outwards laterally towards the ear. Therefore, the light reflex is relatively more nasal, right, within the pupil. The next one down, hypertropia, meaning the eye is turned up. Their right eye is turned up. And then an esotropia of the left eye in the bottom one, meaning the eye's turned in, the light reflex is more lateral or more temporal, right? So for very small turns, if you've got a big turn, like the third one down is a big turn, that's probably quite obvious, right? The hypertropia. But for smaller turns, this is a quick, useful sort of screening exam. Should be symmetric, slightly nasal, get their attention, torch or ophthalmoscope, and then again, both eyes simultaneously. A very common thing is a pseudo-strabismus or a false squint, and you tend to get this in newborns and infants where you have a symmetrical corneal light reflex, but it looks like the eyes are turned in. And this is from big skin folds, which we call epicanthic folds, which are pronounced in newborns and infants between the eye and the nose. If you're not sure whether it's a pseudo-strabismus, obviously you err on the side of caution and refer to an ophthalmologist. But you can see the corneal light reflex there is very symmetric. And look, before 3 months of age, alignment's variable. You know, our 2-day-old, her eyes are all over the place. She's got nystagmus at times, one eye's turning in, the other eye's turning out. Early days, it's normal to have variable alignment, but 3 months onward, they should be pretty consistent. If they've got a fixed misalignment, right, so that one eye is turned in one direction and stays there the whole time, that's different, even if that's within the first 3 months. Yeah. Was that a question? Yeah. Yeah, definitely. Yeah. Especially you could say especially if they're 1 or 2 months old, because the earlier the more critical it is. And you know, for a pediatric ophthalmologist, and there's several around town, that's a very quick, easy, and satisfying consult for everyone. So they're not going to be annoyed that you're referring a possible squint. Yeah. I'm not pediatric ophthalmologist, but I'm going to speak for all of them when I say that. You'd rather catch the 1 in 100 who's going to have a poor outcome, yeah, if they're not seen. Okay, so let's move on to amblyopia. What does it mean? Reduced vision in one or both eyes. And it's pretty common, yeah? 2 to 5%, so up to 1 in 20, due to abnormal visual development for various reasons. What are these reasons? So the 2 most common ones would be strabismus, the eye is turned, right, for whatever reason, so it's not getting the right image. Or anisometropia means different spectacle prescription or refractive power in one eye versus another. So you need a big spectacle prescription in one eye and not so much in the other eye. The big spectacle prescription eye, brain's going to start to ignore that eye until you put specs on the baby, and then it'll pull them into alignment. Or visual occlusion. Visual occlusion means something in the way. Eyelid's in the way. They've got a corneal opacity that's in the way. Just think anatomically. There's a cataract in the way, so on. Presentation. Often it's the parents noticing it, or the child health nurse, or school nurse. So this is often how it comes in. Little ones are not going to tell you. Differentials are simply refractive error with no amblyopia. So what I mean by that is visual development's actually okay, they just need specs. Whereas amblyopia is they do need specs, potentially, but visual development is already lagging. Now, if they keep the specs on, that visual development can catch up, right? And then it might be nothing to do with the globe itself, the eyeball. We might be talking, you know, posterior to the globe, optic nerve, optic chiasm, intracranial pathology. So is there other neurology going on other than just the eye? Management is refer, and what are we going to do? Well, we're going to optimize vision in various ways. So if there's an occlusion, that's the first thing you do is treat that. Cataract gets operated on straight away, even in, you know, tiny babies. Ptosis and eyelid gets pulled out of the way. Glasses if they need it. So they're all, that's all immediate management. How early will a baby tolerate glasses? Very early. This baby's name is Piper, baby Piper. Look her up on YouTube. There's this amazing video where she gets glasses put on for the first time. Has anyone seen this video? A couple of people, yeah. It's so fun. If you want to feel good, watch this video. Because she gets to see her parents for the first time. She's just like amazed. So babies will take glasses if they're the right prescription. They might stuff around with them a bit, but once you've optimized the vision, then if there's still a strabismus beyond that, then they get strabismus surgery potentially, okay? Which means the misalignment gets corrected surgically. One or more of the muscles around the eye gets moved. The insertion of the muscle gets moved. That's the most common operation. And then more specifically for amblyopia, the most common thing is patching the good eye. So you patch the good eye, forces baby or infant or child to use the bad eye. There are doses of patching, you know, how many hours a day, how many doses a week. It depends on how much amblyopia there is. Can go for months or even years. Patching can be a challenge because, you know, a kid doesn't want the good eye to be patched, right? So there's a lot of teamwork here between ophthalmology and the parents. And that's what it looks like in an infant. If patching's just not working, an alternative is a drop of atropine, which can be used once a day or less often and is equally effective. So 1% atropine. And this dilates the good eye, which is a way of blurring their vision. So it's kind of, we call it pharmacological patching. So you're patching the eye using atropine. And the prognosis is good. So, you know, on average, a 3-line improvement on an eye chart, that's meaningful to someone's quality of life and their future in up to 75% of 7-year-olds. So that's up to 7 years old. So that's a very, very good outcome. But up to 12 years, you're still getting some, up to 50% have some improvement. So this is the extended window of visual development that I talked about earlier. And then even up to 17 years old, it's worth persisting if they've never been patched before. So there's still some plasticity within the visual system up to that age. Okay. Yep, question. Why do you only do it 2 to 6 hours a day? It's difficult to do more than that. It can be difficult to do half an hour in some kids. So part of it is pragmatic, but it's also based on these landmark clinical trials that were done of patching, which found the right dose or duration of patching for given levels of amblyopia. So they showed that for mild amblyopia, 2 hours a day is equivalent to 6, so you may as well just do 2. Then there's moderate amblyopia, and then for more severe amblyopia, you want up to 6 hours a day to get a certain outcome. You're saying, why don't you just patch them permanently? Because then the good eye will become amblyopic, right? So you don't want to keep the good eye covered non-stop because the brain will then start ignoring it. So you want to be doing it intermittently. Now you've still got a confused face. So what's the follow-up question? If any. Yes. Atropine can last for days. but the blurring that you get from atropine is not as bad as complete occlusion, right? So the use of atropine has been shown to be equivalent or very similar to patching in cases where you're just not able to patch. And doing atropine on weekends only is potentially as effective as doing it every single day. So if the kid, let's say, needs good vision in one eye for school, if it's a school-aged child, you don't want them being completely blurred in the good eye. You don't want to be doing every day. That stuff's up their school. So then you do it on weekends only, and that's potentially as effective. You may then be sneaking in some patching during the week before and after school. And so, for example, some ophthalmologists will say, let's patch them after school, attempt patching after school, give them screen time as a reward. Then they're looking at a certain target. And if you can do that for, let's say, 2 hours a day during the week and then forget the patch on the weekends, there's various ways to skin the cat. Yeah. Other questions at all, or we keep going? No? Okay. All right, so moving on from amblyopia. This child is looking at a target straight ahead, which is their abnormal eye. And what have they got? Well, they might have an abducens nerve palsy. That's one potential cause. That's pretty rare. They've got a right esotropia, yeah. So you've got about a, I don't know, 2 to 3 year old with a right esotropia. Might be constant or it might be intermittent. What's this girl got? Right esotropia. This person, child, right hypertropia. And this little one, we've already seen this one, I think. This is a pseudostrabismus. If you look at the corneal, it looks like they've got a left esotropia, but they don't. Right, if you look at the corneal reflex. It's central and slightly nasal in both eyes. That might be pretty subtle to you guys, so that goes back to the question before about the referral. You think it's a left esotropia because you're not seeing as much white sclera in the left eye nasally as you are in the right eye, but that's because of the epicanthic folds. She might also have a little bit of a head turn, but it's the corneal reflex that gives it away there. Strabismus, also common, misalignment of visual axes. Let's talk about that. So here's a right esotropia that's been corrected surgically. Okay. So the conjunctiva ends up looking red. Both medial rectus muscles have been operated on. And this wasn't correctable with patching and or glasses alone. So it ended up going to surgery. Okay. And they've got nice alignment in the bottom image, with which most kids do. So what's the etiology? Mainly refractive and then idiopathic. Okay. So an exo or an esotropia. Esotropia is more common. And the most common thing there is a refractive cause, and then followed by idiopathic, or those two together would be the most common. Nerve palsies are uncommon. Syndromic is uncommon. They definitely happen. If you work in a kids' hospital, you'll see those. And history-wise, family history is super important. Increases the chances in kids if parents had it. But then systemic conditions definitely in kids can be associated with strabismus as well. Thyroid eye disease can cause all kinds of strabismuses, not common, but does happen, myasthenia gravis, prematurity, and other developmental issues. So is it intermittent or is it constant? Constant is worse prognostically because the eye is constantly getting a compromised image. And beware an acute onset, because then we're thinking about intracranial pathology, hydrocephalus, that sort of thing. And the most common turn of all is a large angle inward esotropia. So congenital esotropia would be the single most common turn in kids, followed by intermittent exotropia. And an intermittent exotropia, they'll often cover the eye that's affected. The constant congenital esotropia tends to present earlier. So a kid doesn't know to cover one eye. They don't have that motor control to shut one eye. Whereas intermittent exotropia tends to be in slightly older kids, and so they'll often cover the eye that's exotropic or close the eye. And it's done unconsciously. Kid doesn't know they're doing it. And look for the corneal reflex. Yes. There's many etiologies, but the most common thing with constant large angle congenital esotropia is that it's idiopathic and it's thought to be neurodevelopmental. So a problem with alignment in one eye from insertion of the medial rectus muscle. In intermittent exotropia, sometimes it's associated with refractive error, short-sightedness, but not always. Intermittent XT you can sometimes just correct with glasses, whereas a large congenital esotropia is not going to correct with anything. You can patch the good eye, you can give them the right glasses. They're often long-sighted at that age. Most newborns and babies are long-sighted, and you've still got a persistent large turn. And you can almost pick those when they come in the door because the turn's just too big and it's constant. And you go, oh, that's a congenital esotropia, very likely going to need surgery. And it's early surgery that they get. Yeah. Mm-hmm. No. What happens there is one eye just has a certain spectacle prescription, which is substantially higher than the other, right? Higher than the other eye. So the eye that's got the lower spectacle prescription is their preferred eye. They're actually using that for the majority of their useful vision. The poor eye will just rove. It might just rove. It's less common that the other eye will fix in a certain position. It can happen, but it's less common. Yeah. Differentials here, we've talked about pseudostrabismus and then, serious pathology. If they've got an intraocular tumor or a cataract, they're going to have an altered red reflex. So that's part of your assessment, right? So what's the general approach here? Well, it's glasses and patching first. After you've excluded leukocoria or definitely altered red reflex, asymmetric red reflexes, because they're rare. Once you've done that, then what we do is, not me, but pediatric guys, specs, patching, and then surgery if required, right? So the majority of kids end up not needing surgery. But if you go to a pediatric ophthalmology department, it's full of kids who are having surgery. That's where they go. So glasses first, that'll correct a portion. Glasses plus patching will correct the majority of the rest, and then surgery for the remainder. Yes. Yep. It varies. Yeah. So the question is, if you've got refractive strabismus, is that going to be lifelong glasses? Maybe is the answer, because refractive power changes over time, and the eye with the poorer vision, its visual development will catch up over time, so that by the time the kid is 6, 7, 8, they're going to have a lower prescription overall. They'll probably still have a relatively higher prescription in the poorer eye and keep that lifelong, but whether they'll need glasses lifelong or not, I mean, that varies. Yeah, some do, some don't. If it's a very dense amblyopia, they probably will, because that usually means a massive difference between one eye and the other. Yeah. How much? I think in general terms, anything over a diopter and a half. So, spectacle prescriptions are in terms of diopters. I've got a prescription of -6.5. I'm short-sighted. So if I had one eye that was -6.5, one eye that was anything from -5, let's say, down, I'd potentially be amblyopic in the eye with the higher prescription. Definitely 2 diopters, but it starts off at around 1.5. Up to 1 diopter, you might get nothing. You might get no appreciable difference between one eye and the other. Yeah. So what am I saying at the end here? Prognosis is good in the majority. The cosmetic prognosis is good in the majority. The visual prognosis depends on timing and underlying pathology. So if there's no nasty underlying pathology and they're caught and corrected early, then the poorer seeing eye potentially has a very good outcome, almost equivalent. Might not be exactly the same as the better eye, but it may well cause them no functional impairment for their whole life, which is what you're aiming for. And yeah, amblyopia is common. I see adults that don't know they've got amblyopia. So they come in, one eye's, let's say, 6'9", the other eye 6'15". How do I know that the 6'15" eye is amblyopic? As an adult, they've got no strabismus. The eyes, both eyes are aligned. It's not bad enough for them to have strabismus. How do I know that the 6'15" eye, whether it's amblyopic or not? If it's not fixed by pinhole, you know that it's, there's unlikely to be a big refractive component. There might be a small refractive component. And one more thing. So yeah, you're right. That's the single most important, like easy to do test. The other thing is there's nothing else going on in the eye. There's no corneal opacity. There's no fixable other cataract, for example. You can have asymmetric cataract or macular edema. So if it doesn't pinhole up, if the vision doesn't pinhole up or improve with pinhole, or improve with an appropriate prescription, which they subsequently get, and there's no other fixable obvious problem, then that's an amblyopic eye. Yeah. And you've got to wonder why. Often it'll be refractive. They just didn't get the correct glasses as a kid. All right, what's this next topic that I'm going to be talking about? Which core condition? Leukocoria, yeah. So you can agree with me there that there's something abnormal about the left eye. Okay, they're left. Shouldn't see that when you do a red reflex. So you'd be worried about an intraocular tumor here. Okay. And while it's rare, retinoblastoma is, for intraocular tumors, it's common. Overall, it's very rare, thankfully. So we'll talk about retinoblastoma in a moment. Leukocoria in the left eye, again, this one's very likely from cataract. And then here's a series of photos which are auto-corrected with software, which some cameras apparently have now. So that when you use the auto-correction to get rid of red eye in the bottom one, you can miss a potential leukocoria. So what do you do there? I guess you could check your phone settings if you're taking pictures of kids, or, I mean, hopefully someone else is examining your child. But apparently what people do, I'm not phone savvy, apparently what they do is they take a box standard photo and then they'll use an app or a software feature within the phone to get rid of the red eye function. Do any of you guys do this? No. So that's, yeah. So I mean, this is kind of like a public health thing. Parents just need to know to not smudge out the asymmetric red reflex. Or go and see someone. White pupil. So there's a retinoblastoma that's been treated. So these are fundus photographs. So you've got like a mushroom type lesion in the top image, just above the optic disc. There's various ways to treat retinoblastoma. Laser is one of them, depending on size and location. We don't need to get into that detail for the purposes of this lecture. And so when it's regressed, you end up with a scarred area, which potentially causes a scotoma, but depending on where the tumor is, that doesn't necessarily have to have a big functional impact. So in general terms, leukocoria, you've got an absent red reflex due to an opacity somewhere. Now, if you just think logically, front to back, the opacity can be anywhere: cornea, anterior chamber, lens, vitreous, back of the eye, retina, right? Retinoblastoma, in fact, the commonest childhood intraocular malignancy, as I said, 1 in 18,000. We get a few in WA every year. And then cataract would be definitely the next most common one. So congenital cataract. But there are others, okay? Main thing is it's not normal. It's not a see me in a few months. It's immediate referral. They may have associated strabismus. They may have amblyopia as well. Makes sense, right? Got a big lump inside the eye or a cataract in the way, that's going to be an amblyopic eye. Brain ignores it, eye turns. So they often present with strabismus. in a non-verbal kid or a very young kid, they'll present with strabismus. There may be other signs that are obvious. So they've got an intraorbital tumor, a tumor in the eye socket. Then you've got proptosis. If there's inflammation, where you don't necessarily get a red eye, even in kids, you might see a hypopion, which is a fluid level in the anterior chamber of pus. Okay. Cornea might be cloudy. Congenital glaucoma causes that. So look for other abnormalities. And differentials here can be artifact. Difference in prescription alone can cause an altered red reflex. So if one eye is very short-sighted, one eye is very long-sighted, the quality of the red reflex between those two eyes is going to be different. Okay to refer that kid, because one eye may well end up becoming amblyopic anyway. And then strabismus, if one eye slightly turned relative to the other eye, you're going to get a different quality of red reflex, right? So this is referral within days, as in immediate referral to be seen within days. And retinoblastoma, as I mentioned, various ways it can be treated. In WA, it's very often laser, but chemotherapy, radiotherapy, and even surgery can have a role. Very occasionally, a child will lose an eye because of retinoblastoma if it's big enough and, we're worried about metastasis. So kids going to end up getting MRIs, and they get them for years when they've had retinoblastoma, treated retinoblastoma. So they get sedated and then they get a scan done. Yes. Yeah, they are. Yeah. So there's two alleles that are involved, and if both of them are affected, then you've got retinoblastoma. It's called Knudson's two-hit hypothesis, which turned out to be correct, which is both alleles are effective. It can be inherited, or it can be a random mutation. So both of those things are possible. Cataracts are different. So retinoblastoma is a threat to life. Cataracts are definitely a threat to sight, but not to life if there's nothing else going on. But they need, the earlier the surgery, the better. So we're talking about babies that are weeks old having cataract surgery. The longer the surgery is deferred, the more dense the amblyopia becomes. And once you're sort of 3 months and out, they end up with really dense amblyopia. Unfortunately, that will never improve. Yes. That's a good question. I don't think so. It's a long time since I did a pediatric cataract. That would have been when I was a registrar, which would have been 2012, I want to say. From memory, no. From memory, you don't do lens exchanges now. Lens exchange is a tricky operation. So they get a primary intraocular lens, and then the prescription of the eye will change over time. So they'll get a different powered spectacle, essentially, over time. But I don't think I ever saw a case of a refractive lens exchange, because after a couple of months, the new intraocular lens becomes very sticky, gets stuck to the internal eye structures. So to remove it actually becomes a somewhat risky operation. Yeah. Other questions about any of that? No. Yeah, so early surgery, 4 to 6 weeks for unilateral cataract, 6 to 8 weeks for bilateral cataract, followed by aggressive amblyopia treatment very often. Yeah, there was a paper that came out, I think, last year or this year that showed in Australia a very good 20-year survival for retinoblastoma, but definitely lifelong follow-up. Same for cataract, lifelong follow-up. And do not underestimate how urgent both of them are. All right, moving on to conjunctivitis. You probably agree. Cornea looks a bit cloudy. Here we've got periocular erythema, definitely some crusting and discharge. Some discharge in the first image as well. And then really severe crusting, discharge, edema. Okay. So neonatal conjunctivitis within the first 30 days of life. The etiologies, yeah, usual suspects, staph and strep, but the ones to worry about, which is less common, are gonorrhea, chlamydia, and then HSV, which is potentially life-threatening. They can get an HSV, encephalitis. Historically, before my time, silver nitrate was used in kids to prevent. So at birth, silver nitrate was instilled into the eyes to prevent infective conjunctivitis, but it induced a chemical conjunctivitis, right? It's a nasty chemical. So that's not done anymore. More just for interest. Not done in Australia, may well be done in other parts of the world. So you guys would know conjunctivitis very likely if you saw it. Discharge, if it's gonorrhea, they've got an incredible amount of discharge. So gonorrhea is kind of bund or just looks markedly different to the others. In HSV, you can get skin vesicles. Although babies can have that stalk bite sort of appearance anyway, it can be hard to tell. The important thing is, does mum have a known history of HSV infection? So birth canal is important, chlamydia, gonorrhea, or gonorrhea, all that stuff, syphilis potentially in mum. Differential is nasolacrimal duct obstruction. That's what NLD stands for. So quite often in newborns, one nasolacrimal duct is obstructed. And this is just a developmental thing, physiological. Most of them improve spontaneously over about a period of a year. Those kids tend to get discharged, but they don't tend to get the red eye. They don't tend to get the edema. They can get some crusting, but that's an important differential. In those kids, if you press gently on where the lacrimal sac is, which is around where the eye meets the nose, then often you'll see a bit of mucus sort of regurgitate into the eye because they've got an obstruction there. Lacrimal sac's full of mucus. Nasolacrimal duct obstruction is a risk factor for dacryocystitis because you've got all this. So they need to see an ophthalmologist. And then other causes of red eye, they might have had a scratch at birth on the way out or subsequently. Kids like to scratch their own faces, little newborns. Is there a foreign body there? Is there orbital cellulitis or periorbital cellulitis? Periorbital cellulitis is quite common in kids. Not so much in neonates, unless they're systemically unwell. Investigations, yeah, you do a swab, MCNS, and then a PCR for chlamydia and viruses. If they're systemically unwell, then that's all part of a septic workup, obviously. And so the treatment is eye washes, so at least once a day, if not twice. So sterile cotton balls, sterile saline, you've got gloves on. This is, most often be a combination of parents and then possibly a nurse, let's say at a GP clinic doing this, or in an ophthalmology department if we see them. And then bacterial, if we think it's bacterial, that's confirmed on the swab, then that's treated with Chlorsic drops. That's the most straightforward one. Chlamydia and gonococcus require their own antimicrobials. So for chlamydia, it's azithromycin. There are other ways of treating chlamydia, but this is probably the most common for 3 days. Gonococcus is ceftriaxone, and then if it's HSV, that's an admission for IV acyclovir because, as I said, that's the most dangerous one. As with most of the other conditions we've talked about, the prognosis is generally good if it's treated early, but beware the risk of systemic infection or the kid who comes in with the red eyes with discharge but just doesn't seem systemically well, because these bugs can cause pneumonia, encephalitis, and then in the extreme cases, septicemia and even death. So you've got to have a threshold of suspicion. Very uncommon. I never saw a case of an extremely sick child that presented with conjunctivitis, but you've just got to have an index of suspicion. More common is orbital cellulitis, where they're really quite unwell. That's more common than these things. So this is Anita Tandon, who's one of the paediatric ophthalmologists in Perth. I'm not paid to put up a photo of her, but it was publicly available. She knows that she's in this talk. So, you know, common sense stuff, whether you're a GP or another type of specialist, know who your close, as in proximity-wise, paediatric ophthalmologists are, because you might need to refer to them promptly at some point. And there's always PCH, obviously. And good vision is a part of broader, you know, development for kids. It's different to adults. Education, social development, etc. So it's critical to their development, their long-term quality of life. Know those critical windows. And yeah, the first question was about opportunistic screening. So yeah, don't hesitate to dim the lights and pull out an ophthalmoscope just as you're chatting to mum, and kids playing with something can be one of the first things you do. I think that's it. So yeah, hopefully we've covered those things. Questions, guys?